So next is fecal incontinence. A 60-year-old woman has been referred to you with fecal incontinence. How will you assess her in the clinic? I would take a history including frequency of the stools, type of the stools, like Bristol stool chart. It's 1 to 7. 1 is constipated, 7 is diarrhea. Then urgency, use of pads, change of underwear, type of leakage, flatus, mucus, liquid or solid stools, quantity of leakage, strain, teaspoon, full bowel motion, change in lifestyle recently, obstetric history, significant tears, use of forceps, prolonged second stage, previous bowel surgery, IBD, anal surgery, fissure, fistula, onset of menopause. Then I will calculate the fecal incontinence score using the Vasey or St. Mark's score, Cleveland score, or Waxman score. I would perform an examination, abdominal examination, and then inspection of the perineum, looking at the skin conditions for scars and deformity, soiling of the stools, anal gap, previous obstetric injury or pelvic neuropathy, perineal descent, resting pressure on examination, evidence of fecal soiling. Digital examination assessing squeeze tone, anorectal angle, sphincters, length, defects, rectocele, enterocele, evidence of prolapse, mucosal or full thickness. I would perform a proctoscopy, rigid sigmoidoscopy. A rigid sigmoidoscopy may reveal some high-grade interception. I would rule out any proximal colorectal pathology with CT chronography or CT chronoscopy. Depending on the finding, I would request anorectal manometry and physiology an endo-anal ultrasound scan, and would consider the defecating proctogram if required. What are the most likely causes of fecal incontinence in a woman of this age? So there are broad categories: obstetric, internal rectal prolapse or interception, and iatrogenic injury. So obstetric, sphincter injury occurs due to occult tear, missed injury, forceps, damage to the external sphincter plus minus internal sphincter, pudendal neuropathy, long second stage delivery, abnormal perineal descent causing nerve traction or damage, causing low anal squeeze pressures and reducing the anal canal sensation, increasing risk of incontinence with number of vaginal deliveries and the delivery of large babies, internal rectal prolapse, interception, androgenic, previous anal surgery, Lord's procedure or fistula surgery. She had 2 normal vaginal deliveries 2 times with both babies weighing over 8 pounds 10 ounce. Her anorectal physiology shows low maximum squeeze pressure with no evidence of a sphincter defect on the endoanal ultrasound scan and no rectoanal interception and defecating proctogram. So how will you treat her? In the first instance, treatment would be conservative. I would try and achieve a type 3 and type 4 stool using a combination of bulking agents and loperamide. Loperamide syrup is preferable. And glycerin suppositories sometimes can be helped to completely evacuate the rectum along with the rectal irrigation. I would refer the patient for biofeedback if available or pelvic floor physiotherapy. Anal plugs can be used for some patients to control the leakage and promote quality of life. If all these conservative treatment options fail, what other options are there? If she fails conservative treatment, including biofeedback, I would discuss with her about the local pelvic floor MDT and consider sacral nerve stimulation. Even if a sphincter defect was evident, there is little evidence to support a sphincter repair at this later stage. I would check the patient has no contraindication of sacral nerve stimulation, like full thickness rectal prolapse should be ruled out, active IBD should be ruled out, pregnancy should be ruled out, skin disease risking infection should be ruled out, anatomical limitation preventing placement of electrode should be ruled out, severe psychiatric disease should be ruled out, congenital and rectal malformation should be ruled out. I would also ensure that the patient doesn't have a requirement for MRIs in the future. How is sacral nerve stimulation performed? It has 2 phases, a trial phase and the permanent device. So trial phase is for the few weeks and 3 weeks. If it's successful, then patient can qualify for the permanent one. So percutaneous wire is inserted under the local under the anesthesia in third or fourth sacral foramina. Correct positioning is indicated by bellows contraction, anal contraction, and lifting above the perineum and flexion of the ipsilateral big toe. Patients keep a bowel diary pre and post procedure with a trial period lasting 2 to 3 weeks. If a reduction of 50% is incontinence episode is observed, a permanent implant would be indicated. Approximately 75 to 80% of patients experience an improvement of 50% with 50% having normal continence. And posterior nerve stimulation is also an option. How would you management change if the ultrasound showed a large sphincter defect? At this late stage, there is no evidence that sphincter repair may improve this lady's function. It would be combined with the sacral nerve stimulators If the patient was younger, I would consider a sphincter repair in the following situations. So 4 points. If they are symptomatic and have failed conservative treatment, they are non-smokers and have a BMI within normal range, they have a defect of at least 3 arms and a clock face like 11 to 2 o'clock. Patient needs to be warned about the potential risk of defunctional colostomy, risk of wound breakdown, rectovaginal fistula, and a small risk of making symptoms worse. If there was insufficient residual sphincter, a previous failed repair, or a major neurological deficit, I would refer to a specialist pelvic floor center who may consider a further repair and sphincter augmentation like graceless muscle transposition or neo-sphincter in the form of electrically stimulated graceless muscle. Another option is to offer, if the symptoms are severe, would be a colostomy, but there is often a persistent rectal mucus leak from the anal canal. Thank you.